I welcome our moderator, Dr. Aditya Kelkar, sir. Welcome, sir.
Good afternoon.
Now I hand over the session to you, sir. Thank you so much.
Yes, so I think let's begin with Dr. Anirudh Maiti without wasting much of time. And then he's our first speaker.
Good. So what would be the timing for the speaker, sir?
I think we should keep it at 10 minutes with 5 minutes discussion because we have 6 talks in 90 minutes.
Yes, madam.
Okay, ma'am. Yeah, we'll do that.
10 plus 5.
Okay,
All
ma'am.
right. Yes, thank you.
At the outset, I'd like to thank Aditya and AIS for this session.
This video will narrate the stories of arrogant or stiff retina. We don't have any financial interest to disclose.
My audio is clear?
Yeah,
Yes.
perfect.
Main reason for an arrogant or stiff retina is proliferative vitreoretinopathy. Proliferative vitreoretinopathy complicates approximately 5 to 10% of all retinal detachment repairs. Typically, PVR occurs after primary retinal detachment repair. However, it can occasionally occur with long-standing primary detachment. PVR is responsible for 75% of all primary surgical failures. It remains a rock in the shoe of every vitreoretinal surgeon. Retinal detachment with PVR are sometimes like a brake-fed train, which is very, very difficult to react. This is a case of a recurrent retinal detachment with PVR changes. As the membranes are matured and formed, we can easily remove these membranes by forceps. Removal of membranes from posterior to anterior is always safer. Once we release the visible membrane, PFCL is given to see any residual traction. After removal of the residual traction, laser is done. The second case, here the posterior pole has PVR changes causing the puckering of the macula. Here the iron peeling and the epiretinal membrane removal helps the retina to settle without puckering. This is a long-standing funnel RD with posterior membranes. Releasing the posterior napkin-like membrane with the help of a forceps. Once the membrane is released, the posterior pole is stabilized by PFC. Peripheral vitrectomy done to remove all the traction. After doing a good laser, direct exchange of PFCL silicone oil is performed. This is a case of recurrent inferior retinal detachment. Revision of relaxing retinectomy is done to release all the traction and settle the retina. This is a case of an old GRT with extensive anterior PVR changes. Patient had a complicated cataract surgery and was referred. After doing a core vitrectomy, PFCL is given to stabilize the posterior pole. Posterior membrane is released by forceps to unfold the retina. After dissecting the peripheral membranes, the retina is still very stiff due to anterior PVR changes. So, relaxing retinectomy is performed. While performing the relaxing retinectomy, yellowish mass was seen. Eventually, it was found out to be the dropped crystalline lens which occurred due to a complicated cataract surgery. The dropped lens migrated through the giant retinal tear. The dropped lens is emulsified by fragmentome. 360-degree relaxing retinectomy was performed to reattach the stiff retina. Sometimes the membranes are invisible or there is invisible PVR changes. This traction eventually leads to subretinal layer. We tried to take out the subretinal layer through the retinotomy, but the underlying traction was not relieved. There was again subretinal layer. So to relieve the traction, 360-degree encartilage was given by 42 band. After giving the belt buckle, the subretinal layer smoothly came out and the retina settled. So in extensive stiff retina, either a 360-degree encartilage or a relaxing retinectomy is necessary. Sometimes immature membranes causes a very stiff retina. After doing a meticulous peripheral dissection, thick subretinal fluid is drained through a nasal retinotomy. While the thick subretinal fluid came out of the retinotomy, a strange thing happened. In all quadrants, there was spontaneous tension retinotomies and the retina settled by its own. It might be due to atrophic and rigid retina. All the retinotomies were meticulously lasered. .360-degree encartilage might have prevented this kind of unusual tension retinopathy. So to conclude, as retinal surgeons, we should never ever give up. The challenge of dealing immature membranes or invisible PVR is still there. Doing a combined sterile buccal or relaxing retinectomy reduces the intraoperative surprises like subretinal air or a spontaneous tension retinotomies and prevents postoperative maxillary formation. So, we retinal surgeons have to be the superhero and tame the beast in the form of arrogant retina by using enhanced surgical techniques. Thank you.
That's excellent, Dr. Anirudh. I think I will have a couple of questions. One from Dr. Mudit, please. He's our moderator of the session. Do you have any questions for Dr. Anirudh Maiti, sir?
Yeah, hi, Dr. Maiti. Great videos as always. But just a question for you and also for our esteemed panelists, Dr. Rale Banker, sir, Dr. Malika Goyal and Dr. Mahesh. How commonly do you use a dye to sometimes change these membranes? Sometimes these membranes may be immature. Sometimes you see some subretinal membranes also. And using a brilliant blue sometimes makes the visualization of the membranes easier. So how commonly is it used in your practice when you see these complex cases?
Definitely, at times we need to use this, and another instrument what we sometimes use is a finesse loop. Sometimes the immature membranes we can take it out with a finesse loop. I think that helps in many cases where we are not very there is no mature membrane as such.
All right.
I agree with Anirudh. The other tool which I use a lot extensively is the Thanos diamond duster. I use it to gently scrape off all the membranes, even the tough membranes, or even sometimes the invisible membranes, as he showed in one of the cases. And it very nicely actually raises off the edges of the membranes. And then I just squirt in a little bit of IVTA, which actually stains the edges of the raised membranes. And then you can hold your end gripping forceps or a max grip to gently lift it off. So most of the times in all my PVR cases, I usually start my dissection with the Thanos forceps. But as he said, yes, the finesse loop also is very useful. You decrease the size of the loop to make it a stiff kind of a retinal pick-like thing. And then as gradually you are removing the membrane, you can increase the length of the loop, which makes it more flexible. And then you can slowly kind of, gently massage the retina in a very flexible manner with the entire loop and remove all the membranes.
That's a very useful tip, sir.
Yeah.
So
So
do
when
you
you
have some
say-
comment, Dr. Mahesh, sir, please?
I already told the importance of belt buckle in especially inferior PVR has to be reiterated. Many people nowadays don't put belt buckle, but it can save us from extensive relaxing retinotomies. So I think belt buckle has a role in these sort of cases.
Yeah.
When we say mature membranes, like when you see a patient who's developing a redetachment with membranes, would you like to wait for some days to have the membranes mature and complete the, and stabilize? Would you put them on steroids for some days and then operate, or would you operate immediately? So some clarity on that.
I think we don't wait for the case it might deteriorate further. We don't wait the mature to get mature, membranes to get mature. We have to deal with the immature membranes. That's my take.
Anybody else has any other thinking on this?
I think I agree with him. If there's a membrane, I think we should intervene immediately. But there are certain cases, and I've had quite a few cases where you filled in oil, and post-operatively you see a little bit of an inferior fluid or a shallow fluid, but there are no membranes. Then you can still wait. You can ask the patient to position, and most of the times the fluid gets absorbed within 10 days. So it's not that every residual fluid is a sign of intervention. But yes, I think formation of membranes, which is not going to be in an acute post-operative stage. And the membranes are going to develop over a period of 2 to 3 weeks. And if you see these developing and, actually you can see the traction developing, then I think you should intervene immediately.
Yes, I think so too, sir. Because if you leave it around, then subsequently even the retina becomes intrinsically taut and contracted. And then even removal of the membranes may not then lead to, then you'll have to resort to a retinectomy over that area. So I think once you see membranes, it makes sense to intervene at that point of time rather than probably waiting.
And always with silicone oil removal, you can remove some other membrane maturing at that time.
Yeah. Personally, though, I feel that what from experience is that sometimes when you intervene a little early, the membranes do tend to form back because the PVR is still in a development stage. If you just wait for a couple of weeks, maybe with steroids, and then the membranes are thicker, easier to remove, but of course under close follow-up, not allowing the case to deteriorate, but then your chances of recurrence reduce if you have allowed the PVR to reach a particular stage in its development.
That's wonderful. So can we have the next speaker, and that is Dr. Simon Mundel, please?
There's one more point I'd like to make.
Sure,
When we are referred to a case with a complicated, cataract surgery, and the IOL has been put, but we don't see the IOL, we have to be careful. Like you showed the nucleus lying under the retina. I've had finding the IOL under the macula.
Right.
So that is another thing we have to be careful about.
Yes. Point well taken, madam. Can we have Dr. Simon, please? Can you share your screen?
Yeah, very good afternoon. First of all, I'd like to thank AIOC for giving me this opportunity. Am I visible and audible?
Yes, all right. All good.
Yeah, okay. So I'll straight away go to my case. It's a 53 years old lady who had a diminution of vision for 2 years in her left eye. She had had a vitrectomy for macular hole in the left eye in another hospital about a year ago. When she came to us, the best corrected visual acuity was 3/60. And this was the OCT. As you can see, it's a large hole. And these are the parameters of the hole, quite a large base diameter. So I started my surgery. That's a routine 25G pars plana vitrectomy. At that point of time, I used to do 2 valved cannulae and 1 non-valve cannula. As you can see, quite a large hole. I injected the BBG. I tried to stain whatever ILM there was with 2 motives. 1, to do a larger ILM peeling, and 2, to harvest a free flap if that can be put on the hole. But after numerous attempts, as you can see, that could not be done. I tried in a couple of more places. I couldn't. So finally, I decided to go for a retinal graft. The graft area was demarcated by endodiathermy, and it was surrounded by laser. PFCL was injected. And I attempted to harvest the graft.
Wouldn't it be more difficult to harvest the graft under the PFCL?
Yeah, ideally I should. This was one of my first cases. So, I mean, I wanted to show this video also to see the fallacies of what goes on in these kind of surgeries. Yeah, and as you said, that is exactly what had happened. The graft tried to ride over the PFCL, and I had a hard time trying to maneuver it to go underneath. Finally, after some struggle, I could. Yeah, as you can see, the graft size was inordinately larger than the hole. I was using, as I said, a hybrid port system. My right-hand cannula was a non-valve one. So it came out of the PFCL, and before I could realize, it was lost. Then I decided to have a second graft, and it should obviously be a little smaller than the previous one.
This sure requires a lot of guts.
Yeah, finally it was underneath the PFCL, and I could put it at its designated place on the hole. With the graft very well in position, I proceed for fluid air exchange. Now look, the moment I put silicone oil, the graft started migrating. And therefore, under the silicone oil, I had to bring it back in place. Thankfully, my ordeal ended there that day. It had been quite a long day of surgery. And just a minute. Okay. So on the first post-operative week, I was very relieved to see that the graft was still in place. The OCT showed that the graft is in position. This is the 3 months post-operative picture. The graft seems to be well taken. And as you can see, the silicon oil interface. So I did the silicon oil removal after 3 months. Patient visual acuity improved to 6/24. And 1 month post S1, that's the picture. The graft seems to be very well taken. And I was very happy at last to see the ERG. Thank you.
Fantastic job.
Thank you, Dr. Mundel. Great video. And a very nice learning for, I guess, all of our audience, because losing the graft is something which all of us have at one point of time or the other faced. And it's something which has happened to all of us. But it's a nice learning about how you can go ahead, deal with it. And like you said, I, to be honest, still don't use PFCL, but most of the people do. And I kind of now agree to the fact that using PFCL does make our life a bit more easier when we are doing these cases. But thank you so much for showing that video. And any other observations or any comments from our esteemed panel?
I'd just like to ask how he made sure that he had not inverted the flap.
Well, I think I had to rely on about that visibly. I mean, by my visual impression that I'm putting it on the right side, not the upturned side. And I would also like to corroborate with Dr. Mahesh that later on I learned that if I have to put PFCL while harvesting the graft, I'll have to put it full on, full on PFCL, no partial PFCL. Number one. Number two, while I'm harvesting the graft with my cutter, a significant amount of PFCL gets absorbed, gets sucked by the cutter itself. So if you have a little less PFCL, that will get even lesser and lesser once you are turning your cutter all around. So PFCL has to be more than adequate.
Very excellent video. And it takes a lot of guts to show a video with so many problems. So I must congratulate you on that as well.
Yeah, thank you. Thank you.
Thank you. So I think we'll move on, and I'll present my case on optic disc pit with maculopathy. I hope you are able to see my screen.
Yes.
Can you see the screen?
Not your slides though, something.
Yeah, we can just see your folder, but the video is not there.
It shows video folder.
Yeah.
Yeah, now it's there.
Now it's there.
Yeah, so this is a case of a recurrent optic pit with maculopathy. So it's about a 30-year-old girl who presented to us with optic disc pit with maculocytosis, no history of trauma. Anterior segment examination was within normal limits. And on fundus examination, she had this optic pit with maculocytosis. This is the OCT finding. And then she underwent a conventional treatment of double peel, where one flap of the ILM goes over the optic pit associated with a small remnant of the ILM which goes over the fovea so as to prevent macular hole formation. If you try to remove the ILM completely, there is always a risk that a macular hole may form in these thinned out foveas. So the second flap goes over the fovea. The first flap has already gone over the optic pit. Then it is, along with that, I did a papillary laser treatment, and this is the post-operative picture. And a few months later, after primary surgery, she again came back with a recurrence of a huge optic pit obviously the macular edema was much more than the first case. So this time we decided to do an amniotic membrane graft so as to plug the optic disc pit. So this is the video which demonstrates the amniotic membrane grafting being done. This is the intraoperative OCT which confirms the the optic disc pit with maculocytosis. You can also see over the fovea the previous remnants of the ILM, the inverted flap. So we decided to go ahead with this patient with an amniotic membrane graft. We harvested about a 3 millimeters graft because the optic pit size itself is quite big. It was stained with the brilliant blue dye so that once we enter inside, it becomes easy to manipulate the graft in the optic pit. So it was placed over the optic pit, and then slowly, gently, it was tucked inside the optic pit. The snug fit of the amniotic membrane graft was confirmed on intraoperative OCT. And once the optic disc pit is completely filled up with the amniotic membrane graft, we did not have to do any additional laser or any additional PFCL injection or laser photocoagulation or gas injection in this case. So this was primarily only optic disc pit which was treated with amniotic membrane grafting. How useful this optic, the outcome, I mean the impact of the intraoperative OCT is that it gives you a clear-cut idea as to how snugly this amniotic membrane graft is fitting into the pit. And post-operatively within 48 hours, we found that because of the snug fit of the graft, the fluid started to regress. Obviously, this is a pre-vitrectomized eye, so there is not much viscous fluid in this, but it continued to regress, and at 6 months follow-up and at 12 months also, the patient is doing extremely well with well-attached retina, and there's no sign of recurrence. Thank you.
It's an excellent video.
Thank you.
I would like to know, you decided not to put any air or gas, right?
Yeah, because of the snug fit of the membrane into the optic pit, we were quite certain that this is going to work.
Okay. Okay. So you just, I mean, yeah, because you might otherwise worry that there is nothing to tamponate the area and keep it in place.
Any other experience with glue in these cases? Because there are reports or papers which have described use of fibrin glue in plugging these.
So yes, you can use a fibrin glue, or you can even use a the glue tissue fibrin glue, or you can even use the tissue glue for that matter, or a plasmin. That also can work in these cases.
Yeah, the reason I'm asking is that I have used it in one of my cases. It's worked till now, but then surprisingly, one of my colleagues also has used it, and she faced a recurrence after 6 months.
Yeah, I mean, this is a very unacceptable.
Is it possible that amniotic membrane may be a better option because it stays for a longer time as compared to glue?
I guess it's too early to say. If you see my 1 year follow-up picture, it doesn't show any remnant of the amniotic membrane graft there. So we don't know. These are very few cases that we come across in our clinical practice. So it's very difficult to say whether amniotic membrane is better than the fibrin glue or plasmin. But yes, all these techniques have worked. Even Dr. Parag Shah has showed us that even the scleral graft has worked wonders in his experience.
So Dr. Kelkar, would you then now primarily use amniotic membrane graft, or you still go with ILM flap anyway?
I will definitely do the ILM peeling, but I feel that there has to be something that would plug the optic pit, and amniotic membrane graft being very easily available. I would be tempted to use it in a primary surgery as well.
Because I have not had failure when I have been able to put the ILM flap inside, tucking it into the pit. So yes, primarily I'm wondering whether every case should go with amniotic membrane.
I also feel that in both the cases, primarily we have to, these are cases steps resort for recurrent cases. Like the previous case, macular hole was there. A lot of macular holes closed with our ordinary treatment of ILM peeling and gas, even more than 1,000. So this sort of surgeries probably is excellent for a recurrence. That is, so I am also a conservative surgeon. Probably I am thinking like that.
What you're saying is right, sir. I agree with you.
So just a question or an addition. In the previous case, or Dr. Mundel's case, would one go for a dramatic thing like doing a retinal harvest, or would we try to treat that with an amniotic membrane also?
I frankly feel that the retinal tissue that you harvest over the macular hole or even amniotic membrane, it basically works as a scaffold. So I don't think it matters whether you use a retinal tissue or amniotic membrane. I would be tempted to use an amniotic membrane because basically
less destructive.
You don't have another hole in the retina.
Yeah. In fact, one of our colleagues from LV Prasad, Dr. Samira Nayak, has worked extensively in using amniotic membrane grafts for recurrent or failed macular holes. She has an unpublished large data, but what she's also found is very promising results in these failed macular holes with amniotic membrane grafts.
Right.
Ale, what would you say? Dr. Mahesh, what would you say?
Well, for that matter, I think I'm also a conservative surgeon like Mahesh. Even in failed macular holes, I haven't done a single case yet of putting transplanting an ILM. I usually use the massage technique, where again with the Tanos or the loop, I tend to centrifugally massage the retina from all around the hole and try to loosen the entire retina, and then just do the conventional macular hole surgery. At the most, earlier I used to do a lot, and I published a paper also on using the autologous serum. So maybe I just add 1 or 2 drops of autologous serum onto it. But personally, even till today, I don't do an ILM transposition or even an inverted ILM or anything like that.
Yeah, autologous serum I've also used. I've not used amniotic, but that seemed to work very well. It was a bad hole, very large one, and we got pretty good results with that. Yeah.
Thank you so much, all our panelists and all our speakers. Shall we move on to the next case?
Yes, please.
Yes.
So I think I'll go ahead next. And so I'll be sharing with you a video of a patient who had a large hemangioma. And let me just start with my video directly. So is my video visible?
Yes. Yes.
Retinal capillary hemangiomas are developmental vascular tumors occurring either sporadically or in association with the familial cancer syndromes like von Hippel-Lindau. Smaller tumors can be treated with laser photocoagulation or cryotherapy. However, larger lesions can result in exudative macular changes or tractional retinal detachments. They can also have extensive membrane proliferations and can rarely result in a rhegmatogenous retinal detachment. A 45-year-old patient with a retinal capillary hemangioma developed a rhegmatogenous retinal detachment following a cryopexy done earlier. The visual acuity at time of presentation was a Snellen's equivalent of 20 by 200. The patient also had a macular hole at time of presentation.
Mudit, we are not able to hear.
Mudit is muted. Mudit.
Yeah. Can you hear it now?
Yeah.
Yes.
Okay,
Yes.
sorry. Yeah. So this patient had extensive membranes which we peeled, and then subsequently we tried to remove all the membranes from the periphery.
However, in view of extensive anterior membranes, a pars plana lensectomy was also done. The membrane removal over the angioma was then completed. PFCL was then used to flatten the retina. The feeder vessels were diathermized and endolaser was done along the edges of the vessels. The retina was then excised and the angioma was separated. A constant hemostasis was maintained using repeated diathermy and elevating the infusion pressure. The angioma was then excised and removed en bloc with the help of forceps after enlarging the sclerotomy site.
Why didn't you just chew it up with the vitractor?
Subsequently, a fluid air exchange was done and the ILM was stained with brilliant blue. ILM peeling was done for the macular hole. PFCL was re-injected and endolaser was done around the primary break and the retinectomy site. Subsequently, silicone oil was injected. Post-operatively, the patient's retina was attached and the macular hole was closed. The visual acuity had improved to 20/100. At 4 months, a silicone oil removal was done. The retina was attached and the hole had closed. Patient's visual acuity had now improved to 20/50 with an aphakic correction. Rhegmatogenous retinal detachments associated with retinal angiomas offer a unique challenge. However, in this case, a favorable outcome was achieved after a careful and extensive membrane dissection and an en-bloc resection and removal of the angioma.
I think I'll stop my share here. So this was a very difficult case initially because the angioma was so large. We initially thought that we will probably do a buccal to support it, but even that was not kind of working out. So then we removed all the membranes. And the problem with some of these angiomas are that there can be extensive membranes, not only over there, but even in periphery. And unless and until you remove these membranes, your retina will not settle. So like while somebody had asked if I tried to remove it with a cutter, I tried initially removing it with a vitrectomy cutter, but I could not. And that's when I decided to enlarge my sclerotomy and remove it en toto. And now we have a 3-year follow-up actually of this patient. And this patient is still maintaining a visual acuity of 20/50 with an aphakic correction.
Beautiful video, Mudit. Was it associated with the VHL or isolated hemangioma?
No, isolated, sir. This patient was investigated extensively.
I had one girl, repeatedly new hemangiomas were coming. Ultimately, I lost both eyes of the girl, that young lady. No.
So for this, Dr. Mahesh, what is advised for preventing recurrent new lesions is to do a PRP. After removing it and after your surgery is over, you can do a good PRP and possibly avoid new lesions.
Okay.
Of course, I don't treat these things because I just refer to oncologists, but I mean, this is
very rare things.
I tried brolucizumab also in these patients with smaller lesions, but it doesn't seem to be working at all.
I had a question, Mudit. I have operated a few cases also like these. And as you said, it's 3 years follow-up and you don't see any recurrence of ERMs. 3 or 4 of my cases, they developed epiretinal membrane, 2 years, 3 years down the line, even after oil removal. So we've had to do a re-surgery. So what is your experience on recurrent ERMs in these cases?
So exactly, sir. So maybe I was fortunate in this case because I had done an extensive membrane removal, also done an ILM peeling. Probably that saved me over here. But we also have had patients who have had a recurrence. Hemangiomas and also VPRTs. Both of these lesions are notorious for coming back with membranes. In fact, there's a patient of mine in whom I've done now 4 surgeries. Every 6 months, 1 year later, comes back with a membrane. And his visual acuity improves. The reason I'm operating again and again is because his visual acuity still is 6 times.
That's right.
But he comes back with a membrane every 6 months or a year later. So I have till now removed his membranes 4 times. But in this case, maybe because I did an ILM peeling. So in the last case also, I did an ILM peeling now. But even then, now he has got a peripapillary membrane again, which is coming over here. So somehow these VPRTs and hemangiomas do keep on coming back with the membranes. This one was probably lucky that even now, after 3 years, he doesn't have a significant membrane formation over there. Just the inferior areas where we had removed the hemangioma, that is fibrous. But apart from that, he's doing fine.
Do you think long-term systemic methotrexate might decrease the incidence of recurrent formation, since methotrexate is currently being evaluated as a treatment for PVR? So just a thought, if you give a long-term systemic methotrexate, maybe 20 milligram like we use in uveitis, maybe it might reduce the incidence of recurrence.
Possible, sir, good idea, but I mean, no personal experience till now with that. But definitely a biologically plausible idea.
Or even long-term steroids, maybe though how long.
Steroids, yeah, absolutely.
Yeah, any other thoughts from any of our panelists or any of our speakers on this?
Yeah, I have seen these VPTs, they behave very badly, and I had referred one case to you, Mudit, and she was doing very well subsequently. Very bad. So they are, I mean, they are really bad lesions, and you end up with neovascular glaucoma if you don't treat fast.
Yes.
All right. Thank you so much for all your inputs. I think we'll go on to the next video. And I think that's why Dr. Vivek Dave, he is my colleague in LV Prasad, and he has got such an extensive experience in endoscopic surgeries. So I'll ask him to share his video with us. Dr. Dave, on to you.
Mudit, am I visible, audible?
Yeah.
All right. I hope I'm full screen right now.
No, not yet. Yeah, now you are.
Now, all right. So good afternoon, everyone. I'll be presenting a case on endoscopic iris cyst excision, and we'll go through some of our old cases about the experience that we've had in these situations. So this particular case of mine was an 18-year-old male, Marfanoid habitus. Left eye was lost to an old retinal detachment, was thicycle, and presently had an artificial eye in situ. Right eye had a history of VR surgery with silicone oil in situ elsewhere 2 years ago, and he also had a cataract extraction done. So it was a pseudophakic eye with a recurrent iris cyst and silicone oil in situ. He had undergone 2 sittings of cyst aspiration and sclerotherapy over the last 1 year, but the cyst recurred over the next few months. So this is what the presentation was. Vision was counting fingers close to face. You can see that there is an anteriorly displaced iris. The iris is ballooned anteriorly, a lot like what an iris Bombay looks like, but it had this bossylated appearance here. And right in the visual axis, you can see this brownish translucent reflex, which was representing the iris cyst. Due to a constant contact of the iris with the corneal endothelium, there were multiple areas where you can see haze due to localized endothelial decompensation. If we look at the slit photograph of the slit lamp in slit illumination, this gives us a good idea of the approximation or the apposition of the iris's surface with the corneal endothelium. This is what the B scan looked like, emulsified old oil in situ. Now, if you look at the anterior segment OCT, it beautifully delineates how at multiple areas the iris cyst was adherent to the corneal endothelium, and the anterior chamber subsequently had become very shallow. So the clinical situation that we faced was a one-eyed patient, multiple VR surgeries already done, recurrent retinal detachment which was present under oil as seen in the B scan, recurrent iris cyst, and a previously failed sclerotherapy done elsewhere on multiple occasions. So in this situation, we planned for an endoscopic iris cyst excision and laser photocoagulation of the cyst base, along with VR surgery for the oil removal and repair of the retina. The rationale for this was the fact that if you go back and look at literature in relation to iris cysts, it is notorious for recurrences, and these recurrences occur because of residual epithelial cells of the cyst, which can propagate again over time and reform the cyst. So if we have some way in which we can collapse or excise the cyst and also ensure that we don't leave behind any viable cells, that would be the best way to ensure that there is no recurrence. So this is how the surgery proceeded. First, we had to tackle the anterior chamber. So I'm filling the anterior chamber with viscoelastic and doing a sort of a viscodissection between the iris and the corneal endothelium to enlarge the anterior chamber space. And the observation that I've had over the years is when one is doing this, the pressure that is transmitted back on the iris cyst, because the cyst is taut, many times causes the cyst to collapse. So that also, if we do not have this specific approach of going for the complete cyst excision, may give us a false sort of security that we have actually released or removed the cyst, whereas actually the cyst has only collapsed. So after having done sort of a synechial release, we now make an entry into the limbus, and through the limbal entry go in with the endoscope. So herein we will see that there will be iris visible. What we saw here, this is the pseudophakia. This is the iris tissue up here. And in between the iris tissue and the lens, you will see another membrane, which actually is the cyst wall. And this cyst wall is being removed by a vitreous cutter. So this needs to be removed completely right till its base, so as to ensure that there is no reproliferation. When we go completely close to the base, there is a fear of injury to the ciliary body and hemorrhage from there. That is the reason why once we remove this entire membrane, the base, instead of attempting an excision, we photocoagulate it. Because this is pigmented tissue, this will take laser photocoagulation very well, and a nice photocoagulation at the base with confluent retinal laser, just like you do in a retinopathy of prematurity, helps ensure all those cells are removed. Now, this is what the retina looked like. It actually had a shallow retinal detachment, which was also taken care of in the same sitting. So this is what we ended up with. Counting fingers had increased to 20/250 at 3 months. This is the post-treatment photograph. Just for understanding, I will also put a pre-treatment photograph here. So you see how the anterior chamber was shallowed at presentation and how nicely the iris has gone back, has sort of to a great extent got its contour again, and a nice deep anterior chamber with a pristinely clean cornea as of 3 months follow-up. These are photos of a few other cases of ours. To the left, if you see again an iris cyst occluding the pupillary axis. This was a very young patient, 1.5 years old. This is what the patient ended up with once the cyst was removed. Another patient, large sort of heart-shaped cyst, if you can call it, with an extension around the iris towards the ciliary body root. And again, the post-operative picture showing excellent results. A third photograph, very similar to the case just explained, where the anterior chamber was completely shallow and iris opposed to the endothelium. And after a complete cyst excision, the patient did well without having any recurrence. And all these three cases that I have shown are currently in our follow-up with a follow-up duration of 9 months to 1.5 years, varying from patient to patient. So I would say on the higher side, we currently have a 1.5 year follow-up of the patient, not showing us any recurrence as of right now. So thank you for your attention, and I'll be happy to take questions if any.
Thank you, Dr. Vivek. Great videos. And so for all of your iris cysts now, do you routinely think of preferring to going ahead with an endoscopic approach because it helps you in better visualization and probably even examining the ciliary body and any other residual areas which may probably be missed by a conventional surgery?
Yeah, so one thing is the cases are not very common.
Yeah.
But what I have understood right now, also primarily with a lot of discussion with Rajiv Reddy, who is sort of pioneering endoscopy at LVPI, the cysts that we see are usually in the setting of some sort of violation of the eyeball. So either it has to be a trauma, or it has to be someone who has had multiple surgeries. Very rarely do we see cysts which are congenital. Most of them go to our cornea services. So in the subset that we see, there is a possibility of the cyst component actually crossing the edge of the pupil, crossing the iris at the edge of the pupil. This is when they are likely to have a component which is extending behind the iris. If one sees a cyst which is very clearly restricted to the anterior chamber, not really reaching to the pupillary margin, in that situation, the things that I just showed may not have relevance. But if it is crossing the pupillary margin, A conventional attempt to a cyst excision may lead to some amount of cyst wall remnant. And that is where I think an endoscopic examination to exactly know what is the extent of it. And if we see an extent there, attempting to clear it and then laser the base would be helpful.
All right. Any comments from any of our panelists?
Dr. Vivek, are you using 20 gauge probe or are you using 23 gauge probe?
I am largely using a 20 gauge probe. The surgery that I just showed was a 23 gauge, but for endoscopies in general, if say there is a foreign body, if there is a lot of hemorrhage inside the eye, if I'm attempting a vitreous hemorrhage, I prefer a 20 gauge from the point of view of its camera being larger and giving a relatively larger field of view. It makes it a little more comfortable. Also, the 23 gauge illumination actually is not very great. Sometimes even after putting an additional chandelier, the illumination is wanting, and it's a relative struggle as compared to a 20 gauge surgery.
Very true. Just a thing I'd like to add, you need to have a better, video grabber card. Then the quality of the video will be much better, because I earlier had an Elgato basic card, and then we went on for a higher end card, and that's made the videos much more beautiful, much more rich in color and resolution also.
For your endoscopic videos also, sir?
Yeah. For the endoscope only. Otherwise, we have a normal camera on microscope, right? But the endoscope, so what I do is the S video output, we feed it into the card, and that goes into the laptop, rather than trying to grab it from the composite video. Okay, so the composite video has the RGB channels, red, green, and blue channels, but that is a lower resolution, lower quality video. So the endoscopic system, the
Endo-optic
system that which we're using.
Endo-optic C4.
Yeah, they are the only ones who have this. So the Endo-optics system has an S video output also. So you should take that S video output, feed it into the Elgato or whichever video card you have, and then feed it into the laptop. That's what we are doing. So I actually use my laptop with the video card rather than using monitor which they've given. That monitor we have removed. So if anybody wants, I can show you the samples of the video that we have.
Thank you for that input. I think that's an important input, because case to case, if you compare the endoscopy related videos, cut a sorry figure with respect to clarity as against any of the conventional surgical recordings. Thank you.
A couple of questions, Dr. Dave. Very good videos. One is that, some of them have corneal opacity, and that's the reason you might do it for a retinal surgery. So post-operatively, how do you monitor these patients, because you can't see the retina? And second question is, supposing you decide for a corneal surgery, do you do it after you have removed the silicone oil, then again reassess the stability, each of these last two procedures again with endoscope, and then do a corneal transplant, or would you just transplant with oil in situ?
Yeah, I think excellent questions both. Coming to the first part of the question, say once you operate, I understand you are talking in terms of, say for example, a retinal detachment or a posterior segment pathology with an opaque cornea. So you will not get any opportunity to see what the things are in the post-op. So in this situation, we actually, after having done the surgery, especially if it's an oil-filled surgery, where even the B scan doesn't give us good amount of purchase, you just have to take a leap of faith, monitor the IOP, and if the IOP is not going down, it largely tends to tell you that possibly the retina is attached, and it is just at the point of silicone oil removal, when you see inside again, is when you will actually realize whether the things have really worked out or not. Over the years, I have been staging it completely, in the sense the second is a standalone silicone oil removal, then again have the patient in your follow-up, ensure that the retina doesn't detach, which again you can only monitor on the B scan, and then as a third stage, the cornea person comes in and does the graft as appropriate. Yeah. I would feel, or I would assume, that this not only ensures that what you are doing step by step is going in the right direction, combining the SOR and the keratoplasty in the same go, the cornea group is of the opinion that it may sort of have an effect on the corneal endothelium, and their grafts may go down. So that is the reason I would be keen to stage them over. And so the entire process, it's important to explain to the patients that the entire thing is going to go on for at least 4 to 6 months before they see any flicker of vision per se. Because after every procedure, they would expect that something will change. It is not going to change till months down the line the keratoplasty comes in place.
Exactly. Good. Thank you.
Thank you.
Any other opinions or any inputs from our other two panelists, Dr. Mahesh, Dr. Alebankar?
No, I have beautiful videos, Vivek. No, I have no experience on endoscopy. How is the learning curve for endoscopy? In endoscopic surgery training?
Yeah, I think there is a good amount of learning curve. I'm sure Rajiv lost a lot of hair while trying to teach me and
no, I don't have any hair,
skill.
so I was just asking.
Right.
Yeah. No, there is a definite learning curve, sir. The most important thing is that there is no stereopsis. Like what we see in a conventional VR system, we have a bird's eye view where we are seeing from top to down. What happens in an endoscopy, you have got an end-on view. So you only visualize the area which is under the focus of your endoscopy probe. And there are no stereopsis clues over there. You don't. So that lack of stereopsis and this difficulty in orientation takes time to get used to it. But over a period of time, you do develop looking at adjusting certain clues, your blood vessels, how you're approaching, and then you can go ahead and do it. I mean, like what Vivek said, Dr. Rajiv Reddy was the one who started it, and we have all kind of learned from him. Me and Vivek have both been his students, and he's the one who started and taught most of it to us.
Excellent video.
Excellent. I think we can move on to the next speaker, that is Dr. Navneet. Can I have his videos?
Yeah, good evening, everyone. Thanks, the organizer, for giving me an opportunity to present. I just share my video, means a complete presentation. Actually. Sorry. Is it visible? Am I audible?
Yeah.
Okay. So this is my case. This is a case of managing a large traumatic posterior tear with a short-term PFCL tamponade. Patient came with a history of trauma in the right eye with iron particle a day before, and CT scan showed no intraocular foreign body. Visual acuity was PLPR accurate in this eye, and other eye was absolutely normal. Ultrasound showed vitreous hemorrhage with retinal detachment. So this is my first surgery. Like, this was the trauma. Just sutured it, the corneal tear, and went ahead with lancectomy. And this was a kind of vitreous hemorrhage, was a dense vitreous hemorrhage. And then I could see there was a large posterior tear. I just proceeded with by putting putting the PFCL, and then could see that there was a large tear, and it was even extending so inferiorly also. And then finished the vitrectomy. There was a peripheral vitreous which is removed it. So this was all, and even with indentation, as much as possible, I removed the vitreous. Then as soon as like this, and also under PFCL, I finished the laser photocoagulation. Then as soon as I just went ahead with PFCL removal, I could see like in the periphery, there was subretinal blood, which was approaching towards the macula. I tried to remove this blood, but again, as I repeated it once more, but I could not remove it, and again it was coming towards the macula. So then I thought, like, better I leave this case under PFCL, and then I go ahead with a second surgery. And after 10 days, I went ahead with the second surgery. And under PFCL, first I lasered all those suspicious areas and completed my peripheral laser photocoagulation. Then I went ahead with the exchange and removed the PHL, and I could see like the retina was well settled and absolutely fine. And as there was a very short tamponade, I left it again under silicone oil. So this was under silicone oil. The patient had 624 vision after 1 month, and this was the OCT. This was actually my second case, and basically of a very similar nature. The main aim of presenting this is under PFCL, I have noticed that there is less inflammation, there are less chances of ERM formation. I just brought this case because maybe because when we leave it under silicone oil, there is a gap between silicone oil and retina, and there are a lot of macrophages and inflammatory material which accumulates between the silicone oil and retina, and especially in cases of large posterior tear, that there are ERM formations, so which I didn't notice in both my cases. Definitely there is a very few number, not much number, but just a thought to present. Thank you. Any questions or anything?
Yeah, thank you, Dr. Navneet. So these post-trauma cases, specifically the ones with tears, are usually a challenge, and we do end up seeing more extensive PVR, I guess, in these cases as compared to what you would otherwise see.
Yeah,
So,
exactly.
any experience or any points from our panelists for how to tackle such cases? What has been their experience? What are their preferred practice patterns?
Leaving PFCL nowadays, a lot of people do in giant retinal tear also. So it is not a, this is practiced by a lot of people.
How
Yes,
long would you leave it? 2 weeks or more? When do you re-intervene to remove it?
I did it at around 10 after 10 days, but yes, they say like after 10 to 14 days, because there are studies in which they have shown like if we leave it for a longer period, there could be inflammation because of PFCL. So they have shown in studies about for 1 month, but yes, it's always a good idea, like after 10 to 15 days, we should go ahead and remove PFCL.
By which time our laser scarring also would have happened.
Yeah, exactly. Yes, ma'am. So my main aim in this case was like for a posterior tear, like because I was expecting like there could be some membrane formations and all could be there in such cases. So maybe the space was not there and maybe not much experience, but yes, 2 cases did well.
So what do you think was the cause of that bleeding coming from the infratemporal aspect? Because I think the bleeder was from away from the site of the tear.
Yeah, actually, this was a post-traumatic case, and somehow I think it's very difficult to predict in post-traumatic cases the tears and the areas which can bleed after like surgeries. But definitely there was no iatrogenic any injury during surgery which could have caused any subretinal bleed.
You think there was a fluctuation of IOP? Maybe the IOP suddenly went down and there was sudden hypotony which caused the effusion of the blood? Because I think it was coming from deeper layers.
Yeah, it could be, maybe because this was a traumatic case. I sutured the tear also, and sometimes like even when we immediately switch over to air, then there are always chances that the pressure in for a short period like it comes down. It may be the cause, but so for that reason, although my main reason at that time for leaving under PFCL was the subretinal blood which was coming. So somehow, but I have seen in 2 cases like even these posterior tears and macular, they do comparatively better if I leave under PFCL in cases of posterior tears.
What is the longest duration that you left PFCL inside the eye, or anybody among the panels?
I think I have not left after like I usually remove in 10 to 14 days.
Yeah, I have also never left beyond 2 weeks. Usually, not only does it cause inflammation, it can also cause RP damage because of its own mechanical properties. So,
because of
there are studies which have shown that till 2 weeks, you're still under a safe zone. So, even I have never left beyond 2 weeks.
Yeah.
Anybody else with any different opinion or different experience?
We had a very interesting case where this patient was already having a silicone oil filled eye, and there was some lifting of the posterior retina, which was with the break inferiorly. So we added PFCL, and with the hope that we were going to, finish the surgery and remove everything within a week's time. And then the patient vanished, and she came to me after I think more than a year or so, and the whole PFCL oil complex had become like a like mobile oil,
Yeah.
And there was a lot of extensive RP damage. The retina was attached. So, but when we started removing the oil, I mean, it was a nightmare because even at 500 section, it just wouldn't move. So we had to remove with the 20 gauge finally. And so I just an experience I will tell you.
Thank you. Any experience with subretinal PFCL for any of our panelists, any of our speakers, Anirudh, Aditya, Dr. Vivek, Navneet?
Actually, one thing that I have noted is when there is in giant retinal tear, the posterior extent is something like a radial extension towards the posterior side. That extension of the giant retinal tear little posterior. We can get sometimes subretinal PFCL in many of these cases. Small bubbles may get trapped. I had one patient like this I noted the subretinal PFCL immediately after 1 week or something like that. Then COVID, because of the COVID, patient turned positive, and after 3-4 months he came, and then I removed it. I just made it was not at the fovea, little away. That area in the OCT showed complete atrophy where that PFCL was. So subretinal PFCL, especially at the fovea, you can't leave it like that. That is what I feel.
I had a case.
Recently a case where I was trying to inject PFCL onto a retinal detachment area to flatten the posterior pole. And inadvertently, I managed to create a macular hole with subretinal PFCL, and then it had to be drained through the drainage retinotomy peripherally, and then completed the macular hole surgery as if we have a primary macular hole where I do ILM peeling and then manage the proper detachment later on. But it can happen. I mean, sometimes it can be really funny on table to realize that such a thing can happen to you, and then it does.
Yeah.
I had a very similar case, like I left under PFCL and in a same, like a similar very trauma case only, and then removed it. And then when I put it under oil, then there was a subretinal PFCL globule right at the fovea. But I followed up this patient for at least for 1 year, but the vision was maintained at 636. And after 1 year, spontaneously there was a macular hole formation, and that PFCL came into the vitreous cavity, and the vision was well maintained. So still the patient has silicone oil inside, and there is a macular hole, small macular hole. Vision is same. There is no visual deterioration. He has maintained to 636.
So when you have a subfoveal oil bubble, PFCL bubble, as one of the panelists just mentioned, they had, how would you remove it? Would you put more PFCL on the macula to dislodge it, or what? How would you move it away? Without a hole, it's without a macular hole, you see a subfoveal bubble. How would you remove it? You can't make a hole over the fovea to remove it.
So what I have tried one thing, ma'am. What you can do is that you have got this 41 gauge needle, the one with which you inject subretinal TPA.
Yeah.
That's
you can
right.
connect it to your VFC port.
VFC.
And then with the aspiration of that, you can easily enter that PFCL bubble and then aspirate it back. The advantage over here is I have actually faced this 3 times. One was my own case, one was some operated elsewhere, one was my fellows. The first time I tried doing it with a soft tip needle, I made a small retinotomy just at the edge of it. But the problem is that the PFCL bubble tends to move away. It slips away from your needle entry site. So the advantage of a subretinal TPA injecting needle is that its tip is mobile and flexible. You can use it to engage the PFCL, and with your VFC with aspiration, you can just aspirate it back. So I did it in the next 2 cases, and those went on very well. So that is what I used, the 41 gauge needle to aspirate that.
And then you didn't need to laser that.
No, nothing. It was a 41 gauge entry, so
41,
then you don't even need to laser it.
Yeah, I think that's what is recommended. But since we are talking about this subretinal PFCL, I think another tricky situation is subretinal oils, where you have in recurrent PVRs, the oil goes under the retina, and sometimes you don't realize it. You remove the oil and you still see the retina is still stretched anteriorly. And it's probably when you're doing the retinactomy, suddenly a large oil bubble comes into the vitreous cavity. So, and I've had cases where the operating surgeon elsewhere, in one case, actually they had used 5,000, and in another case, they had used Densiron, and we did not have a history. So I kept sucking, and nothing is coming out. And then I probably just realized that this is Densiron. This is not the usual silicone oil. And again, we had to make a larger incision, put in a 20 gauge kind of the IV cannula, and just suck in the Densiron. So sometimes it's very difficult to suck out the Densiron, which actually goes into the subretinal space.
Yeah, that subretinal silicone oil can be an absolute nightmare, sir.
Yeah.
But the presence of that shows that there is some traction, which has not been
absolutely.
Yeah.
Yeah. So most of the times, it's only when you start cutting the retinactomy, the oil comes forwards. You don't, and it's so much like if you see the edge, we feel that it's only a small bubble.
Yeah.
But the more you keep cutting the retina, the entire bubble comes into the vitreous cavity.
All of us see this subretinal oil in our failed PDR surgeries, where there is a reproliferation of membranes, and it's a nightmare.
Regarding the subfoveal PFCL, I had a couple of patients who came, just after in the first postoperative period, I found that the patient had subfoveal PFCL. In both of these patients, I just waited for 2 months. The moment I saw that the laser has been taken up quite well, I went for an earlier SOR, and as has been mentioned just now, a 41G cannula would just aspirate the PFCL. But yes, there is significant amount of RP atrophy if the PFCL remains underneath.
And if the bubble is very small, you can't even make a retinectomy. How close can you go to the fovea? So unless you make a macular hole. So so the bubble has to be of a reasonable size for you to use this technique.
Yes, and it's that omega sign in the OCT that makes us sure that we get for sure that it is subretinal PFCL that we are thinking.
All right, I guess thank you so much for so nice and such valuable inputs, and to all our panelists, all our judges for their inputs and for their insights onto the surgical tricks. To all of our speakers for sharing their videos with us, and I would like to ask my co-host Aditya if he wants to add anything else.
I must thank everybody for spending their valuable time on a Sunday evening and share their valuable inputs as well as their surgeries, and excellent discussion overall. And thank you everyone for contributing to this instruction course once again. And I hope to see you next year again in person rather than this virtual meeting. Thank you.
And I must
Thank you.
congratulate, this might be the only session in the conference which has finished before time.
Yeah.
No, excellent videos, everybody.
Superb videos.
I think we all learned nice trips. So I think we'll put that into practice. Thank you, Mudit and Aditya, for the excellent session.
Thank you, Dr.
Mudit. Yeah. Thanks everyone. All right.
Thank you.
Thank you so much.
Bye-bye.
Have a good evening.
Thank you so much. And I thank all the speakers for the wonderful presentation and moderators to run the session wonderfully. Thank you so much.
Thanks a lot.
Stay safe. Thank you.